Hey, Comparative Politics class, Dr. the Hulk here to bring you a lecture all about smashing the healthcare system. Okay, that one was super lame. I'm reaching the end of my jokes and my shticks here. I'm sorry. Yeah, we're talking about healthcare today. So this is part part two of 3 in our sessions on social policies. So in the last lecture we did with T.A. Trueheart, we did welfare programming, and today we're going to talk about healthcare programming. And the last one, it'll be our last lecture, is going to be about environmental programming in terms of a form of social programming that the government does. So I want to put up this slide here and have us just keep remembering what this is, because we first introduced this idea of market failure several lectures ago now. That again was a lecture that T.A. Trueheart did, market failure. And it's important because it just keeps coming up. So it might just show up on the exam, right? What is a market failure? A market failure, when markets fail to perform efficiently or fail to perform according to other widely held social values. So in that first lecture on the market that we did several lectures ago, we talked about some examples. So we talked about something like externalities as a form of market failure. And here what we're talking about, the classic example, is something like pollution. So it is an unforeseen cost that can really become prohibitive, whether it's to you, the employer, and you're being forced to address it, and it's a cost you weren't expecting, or a cost that the people in the local environment are now expected to pay for your performance, okay? An externality. We also talked about things like imperfect information as a form of market failure, that we just don't have all the good information. We don't have perfect information. So people will make decisions, they'll make business decisions, they'll make investing decisions based on imperfect information. Not ideal, okay? Monopolies is another one, where you have one individual, one company, one industry monopolizing a world market, whether it's a national market, or in this case, really with the era of globalization we're in, we can think about it in terms of global monopoly, okay? In the last lecture then, with market failure and talking about social programming in the form of welfare, we were talking about this idea of market failure when performance does not meet social needs or social values. So the market is not able to provide what we as citizens expect it to be able to provide. So the whole lecture last time was talking about social welfare programming, where the government will step in with social welfare programming to help balance out that market failure. So the last one that we're adding for today then, a form of market failure, is what we call a moral hazard, moral hazards. And this is, in economics, this is a lack of incentive to guard against risk, where one is protected from its consequences. So here we're talking about something like having health insurance. It becomes a moral hazard if people are feeling like, you know what, the market, whether the market doesn't have incentive to insure people, or people feel that they don't have incentive to get insured. And then what ends up happening when they do have some type of medical crisis that harms the market then, okay? So governments will intervene in the case of something like healthcare and provide systems, or create a hybrid form of system of healthcare, being a healthcare provider, okay, healthcare insurance provider. So we're going to walk through the 3 main forms that are currently active in the world today, 3 forms of healthcare system. So the first one is called the NHI, the National Health Insurance System. NHI, National Health Insurance. So this is a healthcare system in which the government mandates that virtually all citizens must have insurance. Government mandated, you must have insurance. So interestingly, insurance in an NHI system is not specific to a certain employer. It's just everyone has it. So it makes it a lot easier to do something like switch jobs, because it doesn't matter if I was working at McDonald's and now I'm working at Wendy's or Home Depot. My insurance is my insurance is my insurance. I don't have to switch to some new company because I'm working for a new company, all right? It's easier to switch jobs. The example, the country that really brought this forward as a program and is kind of the model of this is Germany. Germany has a national health insurance program. Japan has a national health insurance program. Okay. There are challenges here, though. We're going to talk about not only what each of these programs are, but then a couple of the challenges. A challenge for the national health insurance program model is that for poor countries, this is really not feasible. It's not feasible for poor countries to attempt this model because people simply cannot afford insurance. So for the government to mandate that everyone has it, it's just this idea of like, what are you talking about, guy? This is Central African Republic. How is that even feasible? It's not, okay? So that's a challenge of, yeah, it's nice if you can move to that model, but not everyone can, okay? So then you have the second form then is called the NHS, the National Health System. You've often probably heard of this called a single payer system, NHS system. So this is a government financed and managed healthcare system where citizens all pay. Everyone pays into the system either through a separate insurance payment or via taxation. So it could just be that you don't even see it. It just disappears through your taxes. It never hits your paycheck, and through which you gain your medical care. All right. So examples of this would be the United Kingdom has a single payer system, and the US does in terms of Medicare. So with the US system, Medicare covers the elderly and covers disabled. So it's a system for them, it's a protection for them that is this kind of hybrid government supported system, but it's not the only, we're a hybrid system. Challenges. Again, challenges of a government finance system where everyone is doing single payer, we're all paying into the system and floating it that way. In poor countries, doctors and resources are really limited. So it can create long wait times, right? We've probably heard of this before as a criticism of NHS systems. It can be a long wait time to actually get the care that you need, and the care that you get may be low quality care, particularly in poorer countries where, look, this is just the hospital that we have available, and this is the doctor that's available. He doesn't have the best record of this surgery that you need. He's had 3 fatalities this year, but he's the one that's available. All right, so there's that challenge of it's just like, this is what you get. And so that can be particularly in poor countries, the quality of care is lower than in richer countries. All right. The third version then is what we call the market-based private insurance system. So this is a healthcare system that relies on private insurance for the bulk of the population. So medical insurance is typically provided through an employer, and care is provided by private industry. So this is the US model. This is what we're using largely. A lot of countries are in this though. Turkey does this, Mexico does this, the US does this. And so what you do is say, like in the case of me, working here at the University of North Florida, this is a public institution. So I'm on a public insurance program through the state of Florida. And then care is provided by, I can go to doctors that are like within network, right? You've heard that before. So in-network doctors, I can go to any that are in the network for my system. And so a lot of companies will do this. So McDonald's, Apple, state government officials, etc. You get insurance through your work, all right? Challenges of the market-based private insurance system is that the most vulnerable groups of people in the population tend to be left out of this system. So the poorest, the most disenfranchised, the most unable to provide their own private insurance, they're left out of this system. And government programs do not often provide good support to lift them up, to cover them, where the way the market system doesn't. So it leaves many uninsured. Many people are left uninsured through this system. The most vulnerable are the ones that tend to be left uninsured through this system, right? So we're going to walk through 3 common problems within government mandated or assisted healthcare programs writ large. All right, so these are not particular to any one of these. These are broad problems in general of, gosh, why is it so hard to do healthcare, right? So the first one is controlling costs. Some of the challenges. One of the challenges can be wealthier people demanding more and better care, that have to use improved and expensive technologies. And so this can make costs go higher if it's something like, well, we want the most advanced machinery, we want the most advanced technologies, the most advanced surgeries. That will make costs higher across the board if their payments, those that they have those procedures or those equipment are covered by their insurance, then it can make payments go up for everybody. Okay. Also, the idea that in wealthy countries, they have much lower birth rates and much higher life expectancy. So you can imagine that fewer people are being born, but they're living a heck of a lot longer. And so there's a lot more time in their life to be needing to be on healthcare. And as you age, more and more and more and more complications come up. So it's not just you start with, I need one knee replacement, now I need two knee replacements, now I need a new kidney, now I have to go through a heart surgery, and now I fell and I broke a rib, and now so it can keep going, that you're living so long and having a bunch of problems that can happen at the end of your life. But you're not dying from it, ways that you would have in the past, okay? So things that you can attempt to do, if you have something like a large, diverse pool of people in your insurance group, this can be used to control costs, okay? So if you get a really, really big group, so like in government systems, in an NHS system, National Healthcare System, like the UK system, it's everyone in the country is in the system together. That's a huge pool of people. So you have really wealthy people that have virtually no health complications, to poor people that have no health complications, to this middling group of people that aren't super wealthy, aren't super poor. We're all paying into it. And so if I have mega complications here, but I'm in this bracket, the people in this bracket are helping to cover that cost. So you want a very diverse pool of people paying into your health insurance pool so that it can control costs. That's a challenge with the market-based system that we have here in the US, is that we have much smaller pools. Because if you think of something like, it's just you and your employees. So if your employer is providing health care and the pool is only the 600 of you that work at that company, 600 is really not a lot, especially if you're all kind of paid similar-ish salaries, if you have a similar-ish demographic. You don't have as much flexibility, as much range of people paying in and not using it that are covering costs. So it keeps the costs really high in a market system, that we have these smaller pools looped by employers as opposed to just everyone in the country being in one mega pool, right? So other things that we have attempted to do to control costs, they've done some things like instated new policies, particularly in the US, policies like paying doctors per patient. All right, so a doctor does not get paid. This cuts down on doctors doing a lot of unnecessary surgeries. That it's like, oh, well, I'm gonna see you and have you come in for this. You're having some, maybe you have some irritable bowel syndrome issues, and so I'm your GP and I'm recommending this. But you know what? Actually, we could do this random thing, and maybe we could, remove your gallbladder. That might help relieve some of your symptoms. Let's go ahead and remove your gallbladder too, and that will aid your irritable bowel syndrome issues, whatever it is, right? So you can be like, oh, okay, that sounds good. Yeah, I'll have a procedure and have that removed. There's also doctors themselves. So making it per patient is that the doctor, you can't just have a field day and do a bunch of surgeries on a person. There also is a thing that people will come to doctors and want unnecessary procedures. So doctors then, particularly general practitioners, can become what we call gatekeepers. So they'll be gatekeepers and control against unnecessary procedures, which again make the cost skyrocket. If someone is able to use their insurance to not only cover an emergency gallbladder removal, sorry, I keep bringing that up because that happened to me. I had to have an emergency gallbladder removal. Fun fact, I have no gallbladder. Ooh, we'll make that a quiz question, right? Fun fact, this is a medical thing. I have no gallbladder, okay? So anyway, gatekeepers controlling unnecessary procedures. So you can think of something like plastic surgery, okay? Plastic surgery being something that is largely not covered by insurance unless it's something like I was in a horrific car accident and broke my nose and I need rhinoplasty or I need whatever. So, but something like, oh, a tummy tuck or a chin tuck or an eyelash lift, whatever this thing is, eyelid lift or whatever, Botox. So all these unnecessary procedures are often not covered by insurance. That's a gatekeeper mechanism to say, no, we're not going to let you have these unnecessary things be covered by insurance, and then you bill insurance and make everyone's costs go up for your unnecessary procedure. So that's another attempt that they'll try and do. A last thing you can think of is something like co-payments. They will have co-payments as a way to have you, the patient, also be accountable of, look, if you want all these procedures, if you want to come into your doctor for every sniffle and every cough and every stubbed toe, we're going to make you pay for it. So often plans might say like, oh, you can have like two doctor visits, 2 GP visits a year, a dental cleaning a year. For females, like a gynecological visit, it's often like 1 or 2 a year. It'll be in your plan that it's like there'll be no copay for the first 2 or the first 1 or whatever it is. And then after that, there's copays. Like if you're going to come out and see your GP for every single little thing, we're going to pay you for it, right? Or we're going to charge you for it, okay? So those are just some things related to controlling costs, and that being a big challenge with healthcare systems. All right, we'll take a pause here and we'll come back together to talk about the other 2 common problems. Okay, and we're back, and I'm a bunny now, okay? So we're on to common problem number 2, and this is access to healthcare. Access to healthcare. So a major challenge in the poorest countries of the world is that there are very limited resources, limited clinics, limited hospitals, limited doctors and nurses within those hospitals, limited resources within those hospitals for the doctors to use to save your life. So, guys, I can tell you horror stories of my time living in Malawi. Not even a bunch of terrible stuff happened to us, but I can tell you about being at a doctor's office at 6 at night and having to use lights from cell phones to shine onto my child while a doctor did a rapid malaria test in the dark because there was no fuel for the generator for the doctor's office, right? I can tell you about my friend that was a nurse going through nursing school, and that he had to assist on a C-section of a woman at the hospital. This wasn't even a clinic. This was the Zomba hospital in Malawi. Had to do it and be holding the flashlight because, again, no fuel for the generator for the hospital, which means no anesthesia for this woman, no support for this woman other than painkillers that she can, whether it can be intravenous or that she can swallow. And she had a C-section, people, okay? So you're talking about major challenges around the world of people actually being able to access the resources that they need. In my case, right, I ended up having an allergic reaction, had to get a shot. I had to ask the person to put on gloves before she touched me, and then to prep the area, right, which ended up being my ass because it's an allergic reaction. They put the shot in your butt cheek. She prepped the area. She took a cotton ball, and I watched as she picked up a squirt bottle, squirted the cotton ball. I saw the bottle. It was a bottle of Mr. Muscle window and surface cleaner. Okay, this is one of the best hospitals in Malawi. That is what this nurse used to prep my area before she gave me a shot. Window and surface cleaner, right? They're doing the best they can. At least it has some ammonia. I just had to kind of close my eyes and say, oh my God, just do it, just do it. Okay. Challenges people are facing in terms of what is available and the care that they can get. Another challenge, patients often make direct payments to providers without the benefit of insurance. So it is not uncommon at all for patients to have to pay out of pocket the entirety of the cost of their procedure if they want it done, because there is no insurance coverage, all right? This is a huge barrier to healthcare then, of people saying, I don't have $30,000 to cover the procedure I need to save my life, okay? A challenge in wealthier countries then that have maybe an NHS system or an NHI system is wait times, like we said before. So wait times can be longer before you can get the care that you need. Obviously, they have an expedited system if it's something that it's like, I will die tomorrow without this. That will move faster than something like, I need a kidney. Another challenge for market-based systems like what we have is that the access, again, is not universal. I already mentioned this, so that if you do not have health insurance, then you often are not going. Costs of medical care will mean that you will go untreated. Or if you do go and you do get the medical care you need, but the cost of your prescription is so high that you can't pay it, you will go untreated. We are having a crisis in this country at this point in time related to diabetes, that the cost of diabetes medicine has been so astronomically high that people are doing things like rationing their insulin, which is incredibly dangerous to your health, to the point that people are going into diabetic comas, diabetic shock. They are dying because they are not able to afford their insulin, and they are choosing to ration or to not buy the medicine they need because they cannot afford it. If it's between rent and my insulin, I'm making some really tough choices, okay? So the third one then, here, I'm gonna take the bunny ears off. Actually, hold please. Now I'm a lion, okay? So the third problem then, and this is the one that we'll finish with, is public health. Public health issues that can become a challenge for the healthcare system, can become a burden for the healthcare system. So this should not be surprising, since we are currently in a state of shelter-in-place quarantine for a global pandemic. Public health is an issue, people, okay? So in poor countries, things like access to food, access to clean water, these in and of themselves create a public health crisis. The fact that there is not access to reliable food, access to reliable clean water. So you have all these different diseases that are waterborne illnesses, food-related illnesses that you just do not see in the developed world, that are still happening in the developing world because they have this public health crisis of, we don't have clean water, okay? In wealthy countries then, rather than it be something related to access to food and clean water being in the negative, our big challenge in wealthy countries is obesity, because we have overwhelming access to food, and the food that we tend to eat is not healthy food. All right, so over 30% of the population in the US and Mexico is medically obese. All right. Some other interesting trends, though, when we think of public health, things like alcohol and tobacco usage are down across countries around the world. So that because of the work governments, nonprofits have done to encourage people to understand more about the harmful health impacts of tobacco, of alcohol, we are seeing a downward trend in use of those substances. And something else that we can talk about here in terms of globalization, obviously the pandemic, that's the bottom one on the slide, right? The current coronavirus COVID-19 challenge. Globalization has fueled a lot of public health challenges for us. So everything from the global spread of STIs, the big one being HIV and AIDS, insect-borne diseases, Lyme disease, West Nile, malaria, Zika, right? You maybe remember that there was a major Zika crisis, particularly in Brazil, that was happening. And just with the spread of food all around the world and it coming from different places and then getting to your shelves and then getting into your home, higher rates than ever of things like salmonella, hand, foot, mouth disease, all right? And then obviously things that we're dealing with today like SARS and coronavirus. Absolutely devastating to the healthcare system. It's not even worth at this point guesstimating as to what the impact of coronavirus is going to be on the medical insurance industry in the US, to Medicare, to Medicaid. I don't know. I don't know that it's worth even thinking about right now because we are so deep in the middle of it. Obviously, people in that industry are. I'm not thinking about it. Too scary. We're going to have to just wait and see at what point this finally kind of plateaus and starts to come back down before people are actually able to sit down and say, we've got some models for what this is going to do for insurance costs. Okay. I'm going to stop there. Comment or question down below if you have any ideas, if you have anything that you want to add about this. And otherwise, I will see you for the last lecture. The last lecture is going to be on the environment, environmental policy, social policy related to environment and climate change and stuff. So I will see you for the next lecture, and I hope you guys have a great day.